Thank you very much, Dr. Staudinger, for the introduction. And good afternoon, everyone. Thank you for joining me. I'm really excited to present one of my research projects that I've been working on this year. Uh, as Dr. Staudinger mentioned, I have interest in the head and neck region, and part of that is because I have a personal connection to the head and neck um, field. My uncle in 2012, unfortunately, had passed away from a carcinoma in the neck. And so during medical school, I've been very fortunate to be able to explore this field and to further study the head and neck. As Dr. Steinger mentioned, uh, my presentation today is exploring the characterizations of recurrent laryngeal nerves to further methods in identifying structures during neck surgery. I've listed here several anatomy fellows, Michaela, Charlie, and Ben, who were instrumental in helping me execute this research project, as well as Dr. Sloan and Dr. Olinger, who have been mentors and PIs for this research project. This is an IBC approved research project through KCU, and the number can be found at the lower left-hand corner. So without further ado, let's begin. But before I start my presentation, I just wanted to go over the agenda for today's lecture. First, to give everyone a little bit of background on the recurrent laryngeal nerve, I will be talking about the anatomy, as well as the surgical relevance of these nerves, and then talking about how certain studies have looked at the variations within the recurrent laryngeal nerves. After that, I will discuss my research project, talking about the characterization, as well as the materials and methods and the results that I found from my own research project. So without further ado, let's start with our background. As I mentioned, the background, I wanted to talk about just the anatomy and then specifically the thyroidectomies, and then our variations that several studies have found within these specific nerves. So let's start off with my favorite subject, the anatomy. When we talk about the recurrent laryngeal nerves, it's very important to understand that they are branches off the main trunk, the cranial nerve 10, the vagus nerve. The cranial nerve 10, vagus nerve, travels inferiorly along either side of the neck and then travels into the thoracic cavity. Between the right and left side, we see that there are variations in where this branching occurs. On the right side, we see that the recurrent laryngeal nerve travels under the brachiocephalic artery that I have right here with my pointer. And then on the left side, we see that the recurrent laryngeal nerve travels under the aortic arch. As both these nerves travel back up into the neck, they innervate the intrinsic muscles of the larynx. And this makes sense because both the recurrent laryngeal nerves as well as these intrinsic laryngeal muscles are embryologically derived from the sixth pharyngeal arch. The function of these intrinsic laryngeal muscles is for phonation or voice production. And as such, injury to these nerves can lead to vocal cord paralysis. And so, in certain types of neck surgeries, we want to avoid injury to these nerves because they can lead to permanent loss of voice. And so, one of these procedures that are commonly performed are thyroidectomies. Thyroidectomies are one of the most common neck surgeries performed in the US, and approximately 93,000 are performed a year. It's reported that between 1.5 and 14% of thyroidectomies lead to iatrogenic injury of these recurrent laryngeal nerves. And as such, a key step is identifying the recurrent laryngeal nerves during these procedures. What makes it difficult is not only that these nerves are very tiny and small to find, but there are so many variations within the recurrent laryngeal nerves that from person to person. And so many research studies have been performed in order to better understand these variations. Some of these variations that these research projects have looked at are the types of landmarks that we can use to reliably find these nerves in the neck, as well as seeing how these nerves sit within the neck related to these other structures. So there were some research projects I looked at that looked at the orientation of these landmarks and how these nerves sat within the neck. What also makes this further complicated is that these recurrent laryngeal nerves have variations in terms of the branching pattern that they have within the neck. And so, based on some of these findings, I was able to sort of develop my own research project, and I wanted to provide more quantitative research or quantitative data for some of these variations that other researchers had performed. But first, let's talk about some of the landmarks that these researchers had found. In Henry et al. And Kecker et al., they had identified specific landmarks within the neck that surgeons can reliably use to identify their recurrent laryngeal nerves. Some of these landmarks included the tracheoesophageal groove, which basically is this groove that sits in between your trachea and esophagus. They also explained the inferior thyroid artery, which is the arterial supply for the inferior portion of the thyroid gland, was another landmark that surgeons use. There's also the ligament of Berry, or the suspensory ligament of the thyroid. And then there's also the cricothyroid membrane, which some of you may know in emergency situations when an airway is compromised, someone can quickly palpate the cricothyroid membrane and perform an emergency cricothyrotomy to create a patent airway. So these researchers identified these specific landmarks as ways that we could find the recurrent laryngeal nerve. But then there was also other studies which looked at how these nerves sat in relation to some of these landmarks. And so one such study was performed by Thomas et al., which looked at the relationship between the inferior thyroid artery and the recurrent laryngeal nerves. And what they found was that these nerves can sit posterior, anterior, or in between these different these arteries. And on the right side, they found that the recurrent laryngeal nerves actually were more anteriorly, the frequency was more anteriorly, whereas the left side more frequently occurred posteriorly. This same study also then looked at how these branching patterns were varied as well within the neck. And so Thomas et al. Had found that there were some nerves which had no branching pattern, whereas there were other necks that showed up to 5 branches within the recurrent laryngeal nerve. And so the frequency on the right side, once again, varied, where about approximately 89% of the necks they found had some type of branching pattern, whereas on the left side, 75%. And so this variation was sort of interesting. And so, based on some of these different characterization studies, I was able to sort of think about how can I help quantify some of this variation so that surgeons can hopefully more easily identify the recurrent laryngeal nerves when they're performing procedures such as thyroidectomies. And so this leads to my own research project. So the latter half of this presentation, I'll just be discussing how I went about characterizing the recurrent laryngeal nerves, my materials and methods that I went about performing the project, and then some of the findings and what those findings sort of mean. So first, let's talk about how I characterized it. So with the landmarks, we, as I mentioned before, we had found that there are certain landmarks within the neck that surgeons can use to find the recurrent laryngeal nerve. And so I chose to use the inferior thyroid artery, the isthmus of the thyroid, as well as the cricothyroid junction, because both in cadavers and in vivo, these structures are very easy to find. And they can help guide us in terms of finding where these recurrent laryngeal nerves sit. I also was, as I mentioned, interested in the branching pattern, not only just the sheer number of branching that was happening, but also I wanted to help quantify that by explaining and seeing, is there a certain depth within the neck that these branching patterns occur? And so in order to do that, I decided to use the cricothyroid junction, since that was a reliable landmark that was mentioned, but is also a structure that sits midline. And I'll sort of explain a little bit why that's so important in developing sort of the characterization of these nerves. So first, we'll talk about how I went about. So the materials that we used, we had 32 total candidates that were considered in the Kansas City Anatomy Lab. Of those 32 candidates, 14 donors were included based on exclusion criterias, which included any donors that had been hemisected or had a previous neck surgery, such as a thyroidectomy. Those were not included. And so within those 14 donors, we were able to successfully dissect out 27 of those nerves, meaning that we had only lost one nerve out of those 14 donors, which was a really great number that we were able to achieve. The dissection method for this project, so following the Kansas City's first year curriculum in the neuroendocrine block, the students had already dissected out the skin of the anterior neck as well as the platysma. And so from there, in order to visualize the recurrent laryngeal nerve and the related structures that I was interested in, I had to remove the infrahyoid muscles, which are the muscles that sit anteriorly on the neck, and then also remove any of the veins that sort of sat within this region. Some of those include the anterior jugular vein, as well as the internal and external jugular veins. From there, I then looked at the subclavian arteries. I cleaned those out and then found the thyrocervical artery and followed that artery all the way to the inferior thyroid artery, which led me then to the thyroid gland. And then from there, I was able to easily find the recurrent laryngeal nerves within either side of the neck. Once I had all of those things dissected out, then I could begin my measurements. So once again, I just want to emphasize that we looked at specific landmarks and seeing the distance from the recurrent laryngeal nerve to these specific landmarks, such as the cricothyroid junction. And then I was interested in measuring the depth of branching from the cricothyroid membrane, but then also measuring the course of the recurrent laryngeal nerve through the neck. So talking about the landmarks specifically, this is an image of one of the dissections I performed. We have here over my pointer, you can see that I pinned the cricothyroid junction here, the inferior aspect of the isthmus or the thyroid right here, and then the inferior thyroid artery and where it inserts onto the thyroid gland. And then this last pin shows the initial branching of the recurrent laryngeal nerve. And so from these various landmarks, I essentially performed measurements and sought to hopefully characterize and quantify these distances from donor to donor. Once I completed those measurements, the next step was figuring out the branching pattern and sort of the depth at which these branching points were occurring. And so in order to do that, I performed what is called topographic mapping. And so essentially when I talk about topographic mapping, we are creating a grid system where essentially we have an origin point and create an X and Y axis that allows us to essentially quantify where these nerves are traveling through the course of the neck. And so my origin point was the inferior aspect of the cricothyroid junction, which you can kind of see right here. And then from there, my y-axis was the vertical measurement midline from the neck down. And so when we were topographically mapping, we set the y-axis at set increments. And so for my study, I chose to do 1 centimeter increments from the cricothyroid membrane. And so from there, we measured horizontally the x-axis, which was just horizontal from midline. And so you can see here, this red bracket sort of shows how we went about measuring the horizontal distance from the midline to the specific recurrent laryngeal nerve so that we could see how exactly was this nerve traveling through the neck. Once we were able to measure each of the paths of these recurrent laryngeal nerves, I then sought to basically measure the depth at which these branching points were happening. So wherever the branch happened, I would then measure from the cricothyroid membrane down midline and then horizontally so that I could have specific measurements for that. So for the sake of brevity and so that my colleague Dom can present his research project, I have essentially just summarized some of the more peculiar results that I found during all of these measurements. So one of the things that I thought was most interesting was the depth of the initial branching. So between the left and right side, what we found was that the left side, the initial branching was happening much further down the neck than compared to the right. And so in some research studies, they have discussed using the left side um, as a better approach for certain procedures like an anterior cervical disc fusion compared to the right, just because, as we mentioned earlier, the right side typically has more branching than the left. And what I think is curious is that we see on the left side, this branching is happening much further down, which can indicate that we are maybe missing these recurrent laryngeal nerves if we are deciding to do a left side approach with some of these procedures. Another finding from all these measurements that we took was the lateral distance from the isthmus to the recurrent laryngeal nerves. So essentially, one of the measurements that we did take was from the midline isthmus to just lateral or horizontal to the recurrent laryngeal nerve trunk. And so if you can see here, the left and right side have very similar measurements. And so this kind of explains why the isthmus is such a reliable landmark. And when we consider performing thyroidectomies, this may be one of the specific landmarks we want to use in order to quantify and exactly show that if we have the isthmus right here, then we can expect to see on left or right, this is where the recurrent laryngeal nerve should be sitting. And so in our discussion, once again, we talk about the branching of the right side, at least for the initial branching, is vertically closer to the thyroid compared to the left. And so this can be some consideration, especially when we're performing a total thyroidectomy. Surgeons have to identify these nerves, and if we are aware that the right side should be branching much sooner or much closer to the thyroid compared to the left, that surgeons should pay particular attention to the left because this branching may have occurred much lower than they expected. With the isthmus, since it seemed like they were both similar on both sides, this could be an initial landmark that surgeons use to then, going laterally, find these recurrent laryngeal nerves, especially during total thyroidectomies, where they have to remove all of the thyroid gland. They can use the isthmus so that they can find these nerves very quickly and make sure that they don't injure them. With these discussions, I also just want to mention some of the limitations of the research project. As we know, the embalming process can affect cadaveric tissue, and so some of these measurements may vary slightly from in vivo tissue just because how these nerves are fixed may be different than how they would actually sit within the neck in a live human person. We also have to consider that dissection of the nerves, whether through the student curriculum during the neuroendocrine section or during our own research project, could have disrupted the natural course of the nerve through the neck and could also have affected the branching. These nerves are very tiny, and so some of these smaller branches could have been missed just because they are just intrinsically difficult to find. We also have to consider that there was a small sample size with this project just because of the exclusion criteria. As you know, with using the cricothyroid membrane as the midline structure and doing the topographic mapping, we couldn't include any of the hemisected donors, and as such, that excluded a large portion of the donors available to us. Before I wrap up my presentation, I just want to also provide some acknowledgements. First, to Miss Felicia Harris and the KCU Gift Body Donor Program. Without Miss Harris's diligence in coordinating the Gift Body Donor Program and the donors themselves who have graciously provided their bodies for us to perform research, this all would not be possible. I also want to thank the KCU Department of Pathology and Anatomical Sciences, specifically our faculty for their unwavering support throughout my anatomy year. They have been strong supporters of all the anatomy fellows in our research pursuits, and I just want to say thank you. And then a thank you to the first year Kansas City class of 2027, just for their diligence and consideration as they dissected during the neuroendocrine block. They considered my research project, and without their diligence and caution, my sample size would be much lower. These are the references to the figures and data that I had explained in my project, and then that concludes my presentation. Thank you everyone for listening, and I will open up the floor for any questions.